I am Dr. Manish Dhawan and I am working as a senior consultant orthopedics at Sir Gangaram Hospital, New Delhi. I also work in the same institute as Professor of Orthopedics at Gangaram Institute of Postgraduate Medical Education and Research, and I am also the teaching coordinator at Gangaram Hospital. My special interests include limb reconstruction for complex trauma, malunions, non-unions, limb lengthening for single limb shortening and short stature, including achondroplasia. Adult limb deformity correction. I frequently use spatial correction like hexapod, the German fixator, SUV, the Russian fixator, Taylor spatial frame, the American origin, and DefFix, our own Indian fixator. And pediatric limb deformity correction also interests me, including congenital anomalies, clubfoot, hemimelias, genu valgum, varus, and congenital zoodarthrosis tibia. I have 25 years of experience in applying Elizarov, LRS, and doing spatial correction. And I've done my training in Elizarov surgery at various places. In India, I've done in Mumbai, Miraj, Vellore, and done my advanced deformity correction fellowship at Vancouver, Canada, Kurgan, Russia. My learning also included attending the Baltimore limb deformity courses couple of times. I hope my lectures will be useful to you. Today we will be discussing corticotomy techniques, complications, and type of regenerates. Before starting the lecture, I have to give acknowledgement from the material which I have referred is Transosseous Osteosynthesis by Professor J. Elizarov, Operative Principles of Elizarov Assami Group, Textbook of Elizarov Surgical Techniques, Bone Correction and Lengthening, Vladimir Glokiksi, Victor H. Frankel, Treatment of Fracture, Non-Union and Bone Loss of Tibia with the Elizarov Method, Katani, Advances in Elizarov Apparatus Assembly by M. A. Katani, Basic Techniques of Extremity Reconstruct by Mehmet Kakmak, Advanced Techniques of Extremity Reconstruction, Mehmet and Kakmak, Limb Lengthening and Reconstruction Surgery, Svetlana Rosberg, M. A. Katani Atlas for Insertion of Transosseous Wires and Half Pins by Elizarov Method. Now, corticotomy definition, it is defined as a delicate operation which involves the transection of cortex around the bone without cutting the bone marrow. I put a question mark here and we will see later on what does it mean. So basically it is a kind of a controlled fracture of the bone. Other synonyms are compactomy, which is basically very popular in Russian literature, and osteotomy in the Western literature. But osteotomy in other terms means that where you do not preserve the periosteum, so it is not the right term for corticotomy. Now this works on the law of tension stress. During lengthening, the bone collagen columns get deposited along the line of mechanical stress, subject to preservation of local blood supply, periosteum and endosteum. That we'll see later on, as I already told you. Now this works on the Wolff law. We all know about Wolff law. We have learned about this in our schools also. This was given by German anatomist and surgeon in 19th century, and it states that bone in healthy animal will adapt to the load under which it is placed. If loading on a particular bone increases, the bone will remodel itself over time to become stronger to resist the sort of loading. Now, local bone healing factors affecting the regenerate. These are very important where you do the corticotomy. So you should have a very minimal surgical trauma to soft tissue at the point where you are going to do the corticotomy. You should give a very small incision and you should use a 5 mm osteotome to do this thing, or corticotome. So small diameter corticotome or osteotome is required, because if you take a large corticotome or 10 mm or more, it will cause a destructive corticotomy. So you have to preserve the bone forming tissues and their blood supply. The most important is periosteum and endosteum, and presence of local infection can reduce the regenerate. Like if the corticotomy site is infected, it can be disastrous. Soft tissue scarring at local site can cause problem with the healing at incision site and poor regenerate if periosteum is involved. Poor bone stock, like in poliomyelitis and osteoporotic bone, they can be determined to corticotomy and regenerate. Prior radiation therapy, irradiated bone forms less regenerate, so you have to be very careful of doing corticotomy in irradiated bone. Now, systemic bone healing factors affecting the regenerate. Age. Now, increased age can give poor regenerate. Like younger, if you do corticotomy in younger age group, the regenerate is always better. Now, metabolic diseases like diabetes mellitus, rickets, osteomalacia, and Paget disease can cause problem with the regenerate. Calcium and vitamin D deficiency. Steroid therapy is known to reduce the regenerate. So you have to be very careful. And this steroid therapy also, there are so many autoimmune disorders where we give it. So you have to be very careful in dealing limb lengthening in these cases. Connective tissue disorders like rheumatoid, they hamper regenerate formation. NSAID for long-term use. So initially after corticotomy or surgery, you can give NSAID for 2-3 days, not more than that. And after that, tramadol derivative is given. So NSAID can cause problem with the regenerate. Anticoagulant therapy is another determinant to corticotomy. Avoid doing lengthening in smokers. If patient, I basically refuse my smoker patient for limb lengthening. So because the regenerate is very poor in with nicotine intake. Now distraction factors affecting the regenerate, rate of distraction, if it is more then poor regenerate, if it is less it can cause early consolidation. If you increase or decrease the frequency of distraction, which is stipulated by Professor Elizarov's experiments that 0.25 millimeter 4 times a day, you have to be very careful about that. Latency period, if you the stipulated time like tibia and femur, it is around 7 to 10 days. So if you do not follow that, basically 10 days we take it in a corticotomy is done a corticocancellous junction like in proximal tibia. You have to start distraction at 7 days. So if your fixation is not rigid, like your frame is not rigid, then there is a problem with the region, and you have to give adequate consolidation time before you remove your frame, and it is very important. So it is important to do the stress test before you remove the frame. And length of the regenerate means if the regenerate is a very long regenerate, then you have to give more time for consolidation. So these are the factors where you have to be very careful, formation of regenerate and when do you remove the frame. Now there are simple instruments like different varieties of osteotomes, and these are the corticotomes, so which can be used for corticotomy. Now first I will tell you about the classical technique, and then I go into basically saw technique. Now for classical technique, very small incision is given 0.5 to 1 centimeter. Location at the site where bone is close to the skin. Like in tibia, if you feel the shin anteriorly, you can go in the tibia, and in the femur you can go, the femur is palpable anterolaterally, so you can make your corticotomy site at anterolateral level. Periosteal separation and cleavage at the bone site is cut and avoided. Means once you incise the periosteum, you should not separate it too much with a periosteal elevator. Small osteotome, 5 millimeter osteotome is recommended for initial cut, and at the starting the transfer cut of periosteum is made with a number 11 blade. Now De Bastiani technique of multiple drill holes is useful, so I'll show you the animation for that. So what you do, that you take a drill and make at least 3 drill holes, one at the posterior lateral side, one at the posterior middle side, and one at the posterior side. So once you make these drill holes, then it is very helpful for the corticotomy to be clean and it does not shatter it. Now bone is cut with a osteotome and corticotome. Once you have done this thing, so gentle tapping, like it is a very patient operation. So gentle tapping with a corticotome or osteotome is done so that your corticotomy does not shatter. Now cortex is then cut in a fan shaped manner. So you use your osteotome and you cut it in a fan shaped manner, and in this classical technique you try to basically not to damage the endosteum. So in this fashion you do it. Now bleeding should be minimal. Appearance of dark blood indicates penetration of the bone marrow. So you have to be careful about the high pitched sound. High pitched sound basically indicate that the corticotomy has shattered. Corticotomy can be completed after removal of threaded rods connecting the ring. So you have to unscrew the threaded rod and then you do this technique with a plier. You can break the corticotomy like this. Once it is done, you can reapply the threaded rods. Now there is another way in tibia where you break the corticotomy. What you do, that you hold the proximal ring firmly and rotate the distal ring, because the lateral popliteal nerve, it comes in this area. So this is the lateral popliteal nerve. So if you do an internal rotation maneuver, it can damage the lateral popliteal nerve. So in tibia, hold the upper ring proximally firmly and rotate the lower ring externally to break the corticotomy. Now after corticotomy, align the rings and apply threaded rods. Check the corticotomy site for displacement with finger, and if you have an image intensifier, you can check it. Now coming to another method, which is percutaneous giggly saw osteotomy, which gives a very clean cut. Now giggly saw was invented by Leonardo Gigli. Now this technique was also known as Afghan technique, and Petkis and Abdul Sattar basically described it, and this technique is popularized by Professor Dror Pele, and according to him the endosteum has a little role in formation of regenerate. That's why I had put a question mark in my initial slides about the endosteum, because in giggly saw you totally cut the whole endosteum. So two transverse incisions are given where bone is maximally palpable and suture are passed subperiostally, posterior-medially to posterior-laterally. Giggly saw is tied to the suture and pulled, and cortex and medullary canal are cut under protection of periostal elevators. Now I will show you the animation how it works. So make a two small incision, then elevate the periosteum, then you put a thread, and thread is taken out from the other side. At the one end of the thread you put the giggly saw and cut it, and at the upper part you put you protect it with the periostal elevator. So you can see the animation again. So once you cut it, you have to protect the other side with the periostal elevator, otherwise it can cut through the skin. Now what should be the level of corticotomy? You have to avoid the nutrient vessel. The entrance canal is usually at the center of the bone. Metaphyseal segment of bone is more suitable for the corticotomy. Local site is important, like old scars, infection, zone of sclerosis, porosis or cyst formation at corticotomy site should not be there, as they can cause problem with the regenerate. So if you can see the metaphyseal end of the diphysis, this is the right place. If you see, it is basically at a corticocancellous junction. So this is the one of the right sides for it. But in children, you can do anywhere throughout the length of the bone, because they have a lot of good regenerating power. Now I have to talk about what is a monofocal, what is a bifocal and trifocal methods, because they are confusing and they are frequently used. So monofocal is there when two bone fragments next to the defect are transported towards each other, causing shortening. Ideal gap for is less than 2 centimeters. So this is monofocal. Just two ends of the bone are brought together from each side, and this is done to fill the gap. Now coming to bifocal. Now corticotomy is performed outside the injury zone, and fragments are transported towards each other and compressed. Ideal gap is 2 to 6 centimeters. So this is the injury zone, this is the gap. So we have to compress this area, and corticotomy is done at another site at a proximal level. So this is bifocal. So you should not confuse, and these terms are frequently used. And trifocal is two sides of corticotomy, when double corticotomy is done away from the injury zone, and this is indicated when bone loss is more than 6 centimeters. So corticotomy at upper part, corticotomy at lower part, and this is the gap area. So this is a technique when large bone transport or lengthening is required. Now coming to bifocal corticotomy transport, lengthening up to 5 centimeters, bone fragment transport up to 5 to 7 centimeters, stimulation of local blood circulation in the limb without significant lengthening, but for generation of osteogenesis, like in case of pseudoarthrosis or non-union, where you require a good local blood supply, you can do corticotomy. And if you have to do gradual correction of bone deformity. So we will see this animation how this bifocal transport occurs. So you can see that it's a very simple procedure. The middle ring is the transport ring. It works on a single threaded rod. So it becomes very easy with a single threaded rod. Corticotomy is done at upper level. This is the level of corticotomy, and the bone fragment is transported down. So this is bifocal transport. Now coming to trifocal corticotomy transport, lengthening up to 10 to 12 centimeters, bone fragment transportation up to 10 to 16 centimeters by shifting them towards each other, stimulation of osteogenesis in metabolic disorders like Paget disease, osteogenesis imperfecta and Lias disease. So this is used. So we will see the animation for this thing. So if you see two levels of corticotomies are done, one at the proximal and one at the distal. So they will basically fill the gap. Now rate of distraction, optimum is 1 millimeter per day, is 0.25 millimeter 4 times a day. Indications to increase the distraction is young patients up to 12 to 14 years, where there is lot of regeneration power, so it can consolidate fast. Premature consolidation, uncompleted bone cut. So in this situation, you increase the rate of distraction. Indication to decrease the rate of distraction is severe pain after creating a gap of 3 to 4 centimeters, neurovascular problems, poor regeneration. Now, what are the mistakes leading to complication? Large skin incision can cause problems, periosteal separation at site of corticotomy, overside osteotome, poor choice of level, destructive hammering of compact bone. I've already told you it's a very patient operation. Injury to major vessels and nerves, performance of twisting osteotome maneuver before cuts are completed through medial and lateral walls, loss of fragment alignment, stiff joint, preservation of local motor function of the limb during lengthening is the most important. Like your whole surgery will have no benefit to patient if your joints become stiff. So it is very important in lengthening that you have to preserve the motion of proximal and distal joint with a good physiotherapy backup. Now we'll talk about the abnormal regenerates. So one is the hypertrophic regenerate. So it appears before the 20th day, cross-section diameter exceeds the corticotomy site, premature consolidation is a problem, and the remedy is that you increase the rate of distraction. So if you see that it's a thick regenerate more than the width of the bone, so you have to increase the rate of distraction. Now coming to hypertrophic regenerate, there are 4 varieties A, B, C and D. So the first one type is spotty radiographic densities persist after 50 days, indicating the poor vascularity. So you can see the vascularity is very poor and you have to check that what is the problem with the vascularity. So if the patient is a smoker, you can get a regenerate type like this, or some patient has a connective tissue disorder like rheumatoid, you can face this problem, or even sometimes in poliomyelitis where bone formation is reduced. Hypertrophic regenerate type B hourglass configuration indication that your rate of distraction is too fast for central regenerate. So it's a kind of, you can see it thins out in the middle. So this is, you have to reduce your rate of distraction. So this type of picture will occur in that. Now hypertrophic regenerate type C, irregular regenerating bone columns may indicate instability of vascular insufficiency. So if the picture is like this, intermittent columns, so basically your vascularity is hampered or your frame is unstable. So you have to always check your frame in such a situation. Now hypertrophic regenerate type D, focal failure of bone formation indicates local vascular injury or periosteal damage if peripheral. So this is if you damage the periosteum with a osteotome. Now management of hypertrophic regenerate is you can do bone grafting. So this is the actual regenerate during surgery. So you can open the sleeve with a knife and just do the grafting, and you can stitch it also during the surgery. Now fixator removal after lengthening, a month too late is better than a day too early. That means you have to delay it once you decide to, and you have to follow a specific method, like you have to dynamize before removal of the frame weeks prior. Means I dynamize it 3 weeks prior. Radiologically, X-ray must show at least 3 cortices out of 4, anterior, posterior, medial and lateral, in AP and lateral projection, and they 3 cortices should be ossified with a sharp outline of cortical bone. This is very important. Now stress tests before removal, when all uprights connecting proximal and distal fragments are disconnected, patient is asked to use limb in a functional manner. So this is the test, like if you disconnect all the threaded rods and the patient is made to walk, and if he complains of pain, that means there is a problem with the regenerate, so you can re-tighten the threaded rods. So these are very important. Never remove a frame before dynamization and stress tests. Now after you remove also, I recommend that you should give plaster for 3 weeks till the holes are settled, and then you have to give a brace. Now fracture of regenerate, if it happens, you can treat it with a application of a cast. The regenerate, they go into union very fast, or you can reapply your Elizarov frame. So sometimes in non-union or the regenerate is poor, so you do according maneuver. Now these are alternating cycles of compression and distraction. So there are numerous variations, alternate cycles of compression distraction on the same day, or compression for a period of 1 week followed by distraction for the same duration, or sometimes compression for 5 days. So every surgeon has his own this thing. What I follow is that I distract it for 7 days, then I compress for 7 days, then I give a rest for 7 days, and then I do 3 cycles like this of distraction, compression and rest. So most of the time, in more than 90% of cases, with according whenever I can improve the quality of regenerate. And also I found that non-unions go into union when you do this maneuver. So recently parathermo or the teriparatide is shown to have a role. So there are 2 papers which are found in the literature. So first paper is initial study into role of teriparatide in absent or delayed regenerated formation and during distraction osteogenesis, a case series. This is by Bharat Patil, Rajiv Kanse, Sandeep Gupta, Anil Kapoor, Anmol Sharma and Naveen Mittal. So conclusion was the initiation of therapeutic treatment as described in the study may be successful in triggering the osteogenic potential within poor regenerate and help in consolidation and avoid more invasive surgical procedure. Now second paper is the effect of teriparatide on bone regenerate after distraction osteogenesis. This is by Masood Umair, Tahseen Ahmed, Sadia Habib, Rasham Rehman, Muhammad Ahmed and Irfan Kadir. So their conclusion was that it suggested a promising role of parathyroid analog therapy in distraction osteogenesis for promoting bone formation and consolidation. They may have a strong clinical implication in cases of limb lengthening and bone transport. So these are 2 studies, and we require more studies in the literature as to find the exact role of teriparatide. But sometimes I also use it, but we require more studies. Thank you very much, and I hope this lecture will be very useful for the persons who are starting the Elizarov surgery or their initial phase, so that will brush up their knowledge. Thank you very much.